So the title of my talk is Discordance in Biological and Cultural Evolution and its impacts in pediatric myofascial pain. I just work with kids, so this is all related to my work with kids. I'd outline today is talk a little bit about the discordance in biological and cultural evolution, show the impact in chronic current diseases and postulate if this is a factor in chronic myofascial pain. I will be focusing, as indicated, on pediatric myofascial pain and the 6 pillars of health, which I'm going to explain to you, and elements of care that are not well covered in the medical curriculum. Of course, while we do this talk, we've got to acknowledge that 2020 is the IASP Global Year of Prevention of Pain. There'll be a number of book recommendations along the way. Okay, I've got no disclosures. All my photographs are from the internet. If I have any patient photographs, I have permission to use them for educational purposes only. So when we're dealing with pediatric complex chronic pain, it is very complex and there's very little evidence. It'll be a travesty to let you know that in actual fact, there are no randomized controlled trials of any analgesic in chronic non-cancer pain in children as of 2019. And that's a travesty, and that's part of children being the orphans of research, not only in chronic pain, but in medicine in general. The other reason why there's very limited research in complex pain, of course, is because it's such a complex biopsychosocial phenomena. And you'll see here that I've outlined the biological factors, the psychological factors, and the health factors, which all play in together to make each individual child's pain perception very individual for them. I'll just give you a little minute just to read some of those factors. Of course, this is very difficult to explain to children, and I do this in the way of an analogy of a pizza. And I talk right at the beginning of my interaction with any families about the pain perception pizza, which is broken up into segments, which are the biological segments, the emotional segments, and the psychosocial segments. And I find that having mentioned this right up front, it's more amenable to play in the psychological components to care as you summarize your components of care to the family and the child at the end. And I'm stealing the autism quote here. When you've met one child with complex pain, you've met one child with complex pain, because they're all so different. And I work by the Starfish Principle, and most of you will probably know what that is. Original story by Lauren Isley called The Star Thrower. But I can give you a minute to read that, or I'll read it out myself. One day, a man is walking along the beach when he noticed a boy hurriedly picking up and gently throwing things into the ocean. Approaching the boy, he says, "What are you doing?" The boy says, "I'm throwing starfish back into the ocean. The surf is up and the tide's going out. If I don't throw them back, they'll die." The man laughed to himself and said, "Don't you realize there are miles of beach and hundreds of starfish? You can't make any difference." The boy listened politely, bent down, picked up another starfish and threw it in the surf. Smiling back at the man, he said, "I'll make a difference to that one." A principle I use all the time in healthcare, especially when I've got nurses who come to me frustrated about lack of resources. I say, just work on the Starfish Principle. And I think that that's really important. But 6% of the pediatric population have chronic pain that severely impacts their quality of life. Children with complex pain have a worse quality of life than children who've been treated with cancer. And we believe that that is 6% of the population, and that equates to about 57,600 children. Now, we run a complex pain clinic for 2 days a week, and we don't see anywhere near that volume of patients. So can we do better than the Starfish Principle? Well, fortunately, we have Pain BC, who collaborated with us and the Strategies and Innovation Office at BC Children's Hospital, and we created a website specifically designed for self-management strategies for children with pain. And any child in the world that has internet access can use this website. And We've had some quite lovely feedback from some of our families about this website, and it has been really good sending these details to families before they come to our appointment, and some have actually not even required an appointment to see us. So when they do come to see us, they get what we call the multidisciplinary approach to chronic pain: education, reassurance, goal-directed individualized plans wherever possible, with a focus on return to function, and I'll talk about that later. And we call it the kind of the 3P approach, which I'm sure most of you are all familiar with: physiotherapy, pharmacology, and psychology. You'll see here I've documented pharmacology as the weakest link in the therapeutic chain. Well, one of those reasons I've already mentioned is the lack of evidence to support it in children. But the second is that, you know, you're playing a trial and error game with families to see what is or isn't going to work. And usually we're trying to modulate sleep or mood as well as pain when we're approaching pharmacology with patients. But it should be 4 Ps, because the last P should be for the patient acceptance of a symptomatic approach, and their motivation to turn things around and get better is probably the most important factor in changing patients to a recovery of function. And the multidisciplinary approach does have some evidence to support it. We can see increased mood, improved school attendance, decreased healthcare utilization, improved pain, and decreased parental workday losses. The key thing, and the thing that I've really noticed even before we had this evidence, was that the improvements in physical functioning precede improvements in pain. And that's a really important thing. And that was the beginning of my journey of starting to question what's making the difference. Why is it important? Why is the return in function the first thing that needs to change to make a change in pain? Of course, as you start to do more complex pain works, you have more questions about what's working, can we prevent it? And that's obviously important in this year. And I started to think a little bit more about this when I went to a talk in Berlin in 2018. So I'm going to change tack a little bit and talk to you about that. And this was the Fascia Congress in Berlin, and Dr. Lieberman was talking, and he was talking actually about the IT band in plantar fascia, but it was his comment that he made that you cannot understand the human body unless you understand our evolution, and his reference to his book, The Story of the Human Body. And when I read that, I started to really think about, can we apply this to myofascial complex pain? And he gives a very eloquent argument for why our cultural evolution has outpaced our biological evolution, and that in that process, it has led to many chronic diseases like Alzheimer's, obesity, type 2 diabetes, some cancers, non-alcoholic fatty liver disease, and asthma. What he didn't mention, of course, was that we evolved in tandem with our gut microbiome and our mitochondria. And our mitochondria have been around for billions of years. But I would just want to highlight this as we move forward. We became upright bipedal with large, big thinking brains with our current genetic makeup and biomechanics. And this was all kind of finely tuned over millions and millions of years, along with our mitochondria, microbiome, and our immune system. I don't know if you ever saw this aired in 2018, but this is supposed to be the perfect human body, as outlined by Alice Roberts, who says that the human body is a hodgepodge of parts assembled in an untidy fashion with no foresight by evolution. And I guess if you think about evolution as working with what you've got and changing that to adapt to the lifestyle that you have, I guess you can understand why some things that we evolved to do many millions of years ago may not be appropriate in current day lifestyle. So our current hunter-gatherer peoples are the Kalahari persistent hunters and the Hasda tribe in Tanzania. And so what is the characteristics of these tribes? Well, they run for many miles per day, and they do that to hunt down animals. And by persistent hunting, we're talking about hunting in the heat of the sun, because humans can perspire, whereas animals pant. So animals have the disadvantage of not being able to keep going in the heat of the sun, whereas we can run for many miles in the heat and perspire. And so when they're completely heat exhausted, that's the time where the group in their social cooperative groups can really take down a huge animal for meat to eat. And when they do eat that animal, they eat use every last bit of it. And that's an important thing which we need to remember. They're outside exposed to the sun. They have a diverse diet, which is actually minimal meat. It's probably more the gatherer component, which is tubers. And they practiced intermittent fasting because they didn't have food all the time. They had circadian sleep because they couldn't really do very much at night because they couldn't see. And they were very social and cooperative. They had to be to exist and stay alive. And you would exist in families of 4 or 5 who looked after each other. And of course, the flight and fight mechanism was really important, and that's kind of comes down to our current autonomic service systems in current days. When I go on and talk about this, I want you to remember that I'm just a clinician, and I'm cognizant of 2 important quotes. One is from Dr. Charles Burwell, who's a dean of the medical school in Stanford, and half of what we are going to teach you is wrong, half of it is right. Our problem is we don't know which half is which. And probably more importantly, circumstantial evidence is a very tricky thing. It may seem to point very straightforward to one thing, but when you shift your point of view, it may point in an equally uncompromising manner to something entirely different. And of course, I'm happy to come back in 10 years' time to give a new perspective if I'm completely barking up the wrong tree. This has been a very interesting journey. I have, over the last 3 years, gone down many rabbit holes of investigation, looking into this lifestyle and what's happening at a more cellular level. And I'm trying to pull together factors which I see change my patients in my clinic from a what works perspective, and not so much from the evidence that we don't have perspective. And from that, you'll realize the more you know, the more you don't know. And that lovely quote from Richard Feynman, I don't know anything, but I do know that everything is interesting if you go into it deeply enough. And that's very much what I've experienced in the last 3 years exploring this. So let's take Harry on the left and Wesley on the right. Harry's a Tanzanian hunter-gatherer, and Wesley is in your current Western culture. And looking at him, he has what is pretty sedentary. So one of the things that is a big difference between these two is their activity levels. And physical inactivity has been described as the diseasome of as a diseasome, and regular exercise has many benefits. I'm not going to read these all out, but I have highlighted to you the kind of the important things which I think are really key, and the rabbit holes of discovery that I've gone down in the last couple of years. Importantly, improved mitochondrial function, lowered sympathetic tone, improved sleep, modulation of the HPA axis, improved mood, reduced inflammatory cytokines, increased BDNF. BDNF is your brain-derived neurotrophic factor, which is really important in nerve cell support and neurogenesis. reduces chronic pain, reduces glial cell activation. Glial cells are your little immune cells within the central nervous system, and increases anti-inflammatory cytokines in the dorsal horn of the spinal cord. So also, exercise, there's a different phenotype of macrophages in skeletal muscle. If you exercise, you have more M2 macrophages, as you see on that picture there. And when those are stimulated by exercise, they excrete anti-inflammatory cytokines as opposed to M1 macrophages, which secrete inflammatory cytokines. And so therefore, exercise is something which is really important, which stimulates skeletal muscle, mitochondrial biogenesis as well. So we're getting a flavor here that there's some sort of low-grade inflammation. I'm not talking about autoimmune diseases or autoimmune arthritis. I'm talking about a low-grade inflammation which may be having an impact in neuroinflammation and chronic pain as well. The bottom line is that exercise is good. So that's my first pillar of health: exercise interspersed with rest. Okay. So why are so many of my pediatric chronic pain patients the ones who are involved in competitive sports, doing many, many hours of exercise per day, per week? And I believe that's because they're doing year-round competitive sports and maybe focusing on one particular one and getting re-injury and repetitive re-injury. And I was trying to explain that to one of my kids, and he said, "Oh, like the peak of the rainbow." And I thought that was a beautiful analogy, so that's why I put that picture in there. But when you're talking about exercise, it creates more questions than it answers, because yes, exercise is good, but what sort of exercise, how much, how many times a week, what intensity, what sort of exercise? And if you have disease or you're healthy or you're an athlete, that's obviously going to be, that is going to look different about how much you can or shouldn't do. So again, another individualized approach, I think, is going to be where we have to go with this. So in terms of the differences between Harry and Wesley, of course, is their diet. And Wesley, by his crisps, is very much on the standard American diet, which we call SAD. And I have to say, this isn't an immediate recommendation to change to a paleo diet, and there's a number of reasons for that. But nutrition is really important, and it's going to give us a balance of the important components of nutrition that we need, which I've listed there. And the absorbed nutrients that we take in from our nutrition are really essential for CNS health. For example, tryptophan, choline, and omega-3 are absolutely essential for good central nervous system health. And of course, magnesium, which I'll talk about later, is really important and very deficient in our diet, you'll see later on. And what and when you eat has a really important impact on health, disease, and aging. Again, but I'm going to come back to this diagram, and this is obviously different on your age and on whether you're in a disease, healthy, or athletic stage. So it's not just nutrition that's important, but deficiencies in our diet are important. And you know, most of us understand that, you know, you get scurvy with low vitamin C and rickets with low vitamin D, but that's really at the end of a spectrum. What about all of those? What about all of those patients who've got low vitamin C and low vitamin D where there are no symptoms? And you can see from this diagram here that on the top, that 80% of Americans are deficient in omega-3. 60% of Americans are deficient in magnesium, and I'll go on vitamin C as well, and vitamin D is very deficient in our diets as well. And that's not our fault in terms of what we're eating. It may well actually come down to the nutrition in the land. I'll talk about that later. But what we eat really has an impact on our genes, not by changing our genes, but by inhibiting or activating our genes and doing what we call epigenetic change. And the absorbed nutrients that we do absorb are completely dependent on a properly functioning gut microbiome. Now, we know that Harry and Wesley will have a completely different gut microbiome based on their diet. And a lot of you will understand and know all about the good gut microbiome. We have trillions of bugs in our guts. Well, not just our guts, but on the skin, everywhere else. But they're the vast majority in our gut. We're walking vectors for our gut microbiome. And this is absolutely essential for healthy existence. And our evidence around that is related to the Human Microbiome Project, which was launched in 2007, and work on fecal transplants and germ-free mice. And the key is that the dietary diversity with high fiber content seems to be what is key for a good microbiome. And this is not a recommendation to purchase probiotics, and if anybody's interested in the answer to that, we can talk about that after this webinar. But fascinatingly, if you take the identical twins, one who's slim and one who's fat, and you take a fecal transplant from the obese twin and implant, well, both twins, and implant them into germ-free mice, you'll see that you'll cause obesity in that germ-free mice from the obese microbiome. Mice have got this disgusting habit of eating poo. So if you house that obese mouse in with his friends with the same chow, then he'll become slim again. So that really shows the importance of gut microbiome. And if that doesn't convince you, then if you do a fecal transplant from an MS patient to a germ-free mouse, you'll induce encephalomyelitis in that mouse. And what's happening in that mouse is there's some immunomodulation and some intestinal change and immune change as well. So I'm just trying to emphasize the importance of a good functioning microbiome. Or what causes a bad microbiome? Poor sleep, high glucose fructose drugs, especially antibiotics and non-steroidals, pollutants and toxins. And it's presumed that with a bad microbiome, that our gut lining is less, and it enables the intrusion of endotoxins like LPS from bacterial walls, and it triggers a cytokine response and a low-grade inflammatory state. And that then, of course, then triggers some neural and central nervous system change as well. So the gut microbiome is basically an epigenetic modulator. And there's feedback between the gut and the brain, the gut's being called our second brain, dependent on what nutrients the gut microbiome is exposed to and what it's absorbing and what it's converting. And so there's a really important link between the brain, the endocrine system, and the immune system. And the bad gut microbiome has been linked to all of these chronic diseases, and kind of the list is the same as the one I showed you before, and related to cultural and biological discordance. And this list kind of keeps popping up as we go through this talk. Okay, obesity. So 86 pounds is about 40 kilograms. 40 kilograms is about the weight of a 11 or a 12-year-old, and those are not the feet of a 12-year-old. And obesity is a big problem. It's not as bad as it was in 2004, but still 30% of the pediatric population is obese. And there's a significant association between obesity and pain. But it's, for my practice in my population, it's not an increased risk factor for musculoskeletal pain. And interestingly, if you do pain experiments on obese individuals, they are not more sensitive to experimentally induced pain. So it's something else. So interestingly, if you take two populations of obese patients with migraine and you give one bariatric surgery and the other one weight loss regime, and they both get to the same weight, then the bariatric population have significantly less pain at the same weight and also decreased inflammatory markers. So what's the reason? Well, maybe that's the gut microbiome too. And we can see on the far right that the bariatric surgery patients have a high diversity of gut microbes, whereas patients who have a lap belts, which don't work very well, don't. And so that might be another indication that nutrition and the microbiome are really important components in our health. So I've created two of my pillars, healthy nutrition and exercise and rest. So you see I've added in an intermittent fasting here. And intermittent fasting has been classed as medical bariatrics. And for those of you who have not read this book, I would recommend it to you, especially if you're looking after anybody with type 2 diabetes. And it talks about intermittent fasting, time-restricted feeding, and calorie restriction, which are three different things, and their importance in autophagia. What is autophagia? Well, autophagia is a self-preservation technique that allows the body to remove dysfunctional cells, including mitochondria, at times of fasting, and they use the organelles for energy, but also get rid of the organelles which are not functioning as well as good organelles. And there's been this lovely review in the New England Journal of Medicine last year, providing some of the information on the benefits of intermittent fasting. If anybody's interested, it's a very good article. But you can see that there's a huge number of cellular mechanisms happening here which are related to intermittent fasting. And the benefits are not related to weight loss. And you can see one of the things that the advantages there is increased mitochondrial biogenesis. And so the mitochondria are really important in muscle health. They're the powerhouses of our bodies. But when they're working too much, they create free radicals. And this may be another thing which may be stimulating an inflammatory response. And dysfunctional mitochondria have been associated with that list that I told you, that I showed you before, very similar. And mitochondrial medicine is really realizing the importance of intermittent fasting and good nutrition in healthy mitochondria. And that book there is a fabulous read for anybody who's interested in delving more into the mitochondrial function. Okay, so obviously intermittent fasting is not something we can do for children. Children need healthy nutrition, and the word diet should never be used near a child. But the one thing that we can do is try and limit the snacks that they have between meals, and especially sugary loaded drinks like this one, because of the effect that they're having on metabolism and mitochondria. So the other thing which is different between Harry and Wesley is very different insomnia rates in the populations. Only 1% in the hunter-gatherers and up to 20 to 40% in not so much children, but certainly adults, although we do have sleep problems in our chronic pain patients. And I just want you to think about how much sleep you got last night. Was it 8 hours like the doggy on the left, or was it next to nothing like the guy on the right? Another book recommendation for you, the book by Matt Walker, and also watch his TED Talk. It's absolutely fabulous. And he says sleep is a non-negotiable biological necessity. And we need 8 hours sleep a night because we need to be able to get into stage 3 and 4 REM sleep. Teenagers probably need more. And during that stage 3 or 4 REM sleep, we kind of do a brain washout called lymph and get rid of some of the proteins and metabolites that we don't need in our brains. And even 6 hours of sleep per night has detrimental effects on our brain function, learning, mood, and memory, on our metabolic function, causes epigenetic changes, and makes you look less attractive as well. So get 8 hours sleep a night. And The WHO have classified shift work as a carcinogen to just show you really how important sleep is. So that's my third pillar of health. The other pillars of health are, of course, come around mind-body connection. And one of the things which is kind of not talked about a great deal, with COVID, we know that there's been a big increase in domestic violence. But when people mention domestic violence, they don't mention non-accidental injury. And this kind of adverse childhood experiences are really hidden under the radar. And for those of you who really want to see the effect that adverse childhood experiences have, should read the book, The Body Keeps the Score. It's a fabulous but very kind of tear-jerking read. And the other one, of course, is the effect of repressed emotions on the on subsequent disease, if you want to read the book by Gabor Mate. And chronic stress, of course, is going to have an effect on our HbA access, on our cortisol levels, and on our immune function as well. So it's really important that when we're dealing with our children, that they have a supportive and social network, they have supportive peers and family, and really the important things to help modulate the autonomic nervous system, like yoga and mindfulness, are really important, as are ongoing psychology support and counseling when that is required. Okay, so my 6 pillars of health are these, and I would say that they are cyclical 6 pillars of health, and they are having an impact on all of those little bubbles in that Venn diagram there. And that's what I think is having an impact in our patients with myofascial chronic pain. So I'm going to change tack again, and I'm going to tell you a starfish. This is a 12-year-old girl, 77 kilos. So I told you a 12-year-old should be 40 kilos. So you can see that she's overweight. She's had pain for 6 years. Oh my goodness. Began with tailbone discomfort, no inciting event, no pain-free times. Irritable, fatigued. Pain affects her sleep, her concentration, and her thinking. She had an MVA, but it was after the beginning of her pain, but she did have a fall at age 2, and she's significantly impaired by this, with a lot of school absence. Family history unremarkable, other than the associated increased body mass index. She had a full workup by every man and his dog, and came to me with no diagnosis. I did a myoactivation examination on her and informed her that she had a myofascial component to her pain as the biological segments of her pain perception pizza. And we enrolled her in the 3P care plan and multidisciplinary approach. I stopped her calcium, started her on what I call my muscle health supplements, which are magnesium, K2 and D3, and gave her some advice on our 6 pillars of health. And then we went and told her about why I thought that she had deficiencies in her diet. And that's because our SAD diet has high calorific content and very little in the way of good nutrients. And that's not our fault. It's because of the way that we're farming the land, and the soil is sick. And so there are a number of deficiencies in our diet, even when we've got really good, what we believe is really good diets. And these essential nutrients and foods are really important for our microbiome, for our mitochondria. So the rationale for the muscle health supplements are because of assumed nutritional deficiencies. You can't really, I can measure the vitamin D3, but if I measure the magnesium, then the magnesium is only present in 1% in the plasma, 1%. So it doesn't really give me any indication of what's happening in the muscles where it's important. So I'm assuming a magnesium deficiency when I prescribe these. And magnesium is also anti-inflammatory and essential for mitochondrial function as well. So it hits on a number of different fronts. And the D3, of course, is because of insufficient sun exposure. We've got so tied up in sun exposure and melanoma risk, which of course is really important, that we're not getting enough sun exposure. And the omega-3 is because omega-3 is the building blocks of resolvins, which are a new family of molecules which have been found, which help to switch a trigger from inflammation to anti-inflammation. And that's my reason for trying to focus on more omega-3 in the nutrition as well. So just based on the lifestyle changes and our muscle health supplements, she came back a month later with a reduction in pain, improved fluidity of movements, and improved mood. We did 3 series of myoactivation sessions for her. And after the 3rd myoactivation session, we managed to wean all her medications, and she was discharged from care with no pain, improved cognition, and less fatigue. And this was her quote for when she was discharged, which is quite a little bit of a tearjerker. But this journey is consistently repeated with many of my patients with myofascial pain in the clinic. But you can look at this, as Sir Arthur Conan Doyle says, you can look at this from a different perspective and say that that's just an injustice. A girl who's had pain for 6 years resolved in 2 or 3 months. And why is that? That's because myofascial pain is kind of very unrecognized, although it's very prevalent. And you'll see here, I've documented that 40% of children have myofascial pain. 4% of them are presenting to primary care with musculoskeletal issues. And it's the leading cause of disability in children and adolescents. And even in 6-year-olds, in 10% of 6-year-olds, with 44% of them saying that it's multi-site. And why is it unrecognized? Well, because it mimics other pathologies. So if you've got a QL and quadratus lumborum muscle which sits in your back in sustained contraction, then it mimics appendicitis. So it's not surprising that myofascial pain often goes unrecognized. Other reasons why myofascial pain is unrecognized is because the classic medical culture doesn't recognize the importance of skin, scars, and fascia. Classical medical history doesn't realize the timeline of lifetime trauma and the importance of those traumas in subsequent myofascial dysfunction. The earliest significant trauma is probably going to be the most significant one. I can tell you that this baby with his chin scar is at risk of having some mood disorders when he's older, just from just from my experience of releasing chin scars in myoactivation. And of course, that comes down to how we are seeing our patients, and there's a big time pressure for GPs and ER docs when they're looking after families. So I adopted myoactivation in my pediatric practice in 2017. It's been a paradigm shift in how I assess and manage my patients with myofascial dysfunction. And the big nugget with this is that the site of pain is often not the source of pain, except in the neck. And for me, this has just been such an effective tool in my toolbox, as well as my multidisciplinary approach that doesn't rely on medications. And for those of you interested in a more detailed read about myofascial components of pediatric complex pain, I would advise you to have a look at this article, or just email me if you're interested. So you can see that I started in the bottom down right-hand corner here about evolution in culture, but then went down all these different rabbit holes of discovery, and all of these components are having an impact in our young people that have myofascial pain. And so it's really difficult to take each individual part in isolation. Human biology is obviously so complex. If you try to manipulate just one factor, you may have unintended consequences on the other. And common sense just dictates that we should adapt to our evolutionary biology by addressing some of these 6 pillars of health. I'm not recommending we go back to being hunter-gatherers, but actually adopt some of these 6 pillars of health that I've discussed. It's provided some significant clinical impacts in my practice for pediatric myofascial pain. And to that end, I'm going to recommend that we have a kind of a who ladder of analgesics. This is my ladder of complex pain care, and that we start with lifestyle educations. We work on the 6 pillars of healthy lifestyle. Then we go to pain education, reassurance, and all of the other things that we normally do for our complex pain. And I'm coming back to the Starfish Principle. Well, the man comes back the next day with a huge group of friends to help the boy throw many more of the starfish back in the ocean. And that's what I'm after. I'm after some help to make change and make people realize that these lifestyle changes are really important and helpful for their bodies. And in this year of the global year of prevention of pain, I think we need to protect our children, especially from adverse childhood events and chronic stress. They need fun exercise to the peak of the rainbow for them. They need to be avoiding any unnecessary drugs, especially antibiotics that are going to have an effect on their microbiome. Their nutrition needs to be balanced, unprocessed foods. They need some sun exposure, but obviously not at peak sun times, but some sun exposure. They need 8 hours of sleep, and we need to, COVID has really made a change to how kids sleep, and that's been a great advantage. We need to lobby for later school starts. We need to teach resilience and mindfulness as a basic component of childhood care. We need to recognize and treat myofascial pain early. And maybe we can prevent the development of chronic pain in kids, especially myofascial pain. And I'm here to advocate and ask you to advocate for resources for chronic pain management, audit, and research in children. So in summary, I've talked a little bit about pediatric, mainly myofascial chronic pain. I've talked about the multidisciplinary approach. I've talked about evolutionary mismatch and its effect on chronic diseases. We've talked about how myofascial pain is so unrecognized in the community at the moment. My 6 pillars of cyclical health, and that this is a foundational basis of ongoing lifestyle that we need to readapt to help our evolutionary body. And that's it. That's the end of my talk. Anybody got any questions? Please push them through to Jen. And of course, I'm very happy to be contacted by email if anybody's got any questions. Thank you, Jen.
Thank you. That was a fascinating talk.
Just stop sharing.
Yeah, very wide-ranging. So there's a couple questions. So as Jill said, we have a few minutes, and there's a lot of content in there to unpack. So I'm sure everyone will have a question. Just put it in the Q&A or the chat, whatever you like. So Jill, there's a couple questions in there right now. So this is a good one. Is there any way we can objectively measure whether a gut microbiome is good or bad? And what do you measure when determining change in it?
So I think the microbiome science with its relevance to chronic pain is really in its early stages. And that's why I said that I wasn't recommending any probiotics. Probiotics are completely unregulated currently. And unless they're coming refrigerated, they're probably not effective. And they've got to be delivered in a mode that can actually reach the colon. And so there are microbiome measurements of what the diversity of the bacteria and microbes are in the gut, but what relevance that is and what effect each different species is happening is still very early days. But I think and the answer to that is, my simple answer to that is that yes, we don't know the answer to these things at the moment, but let's take a common sense approach and adapt to what our microbiome's like, which is high fiber vegetables and some meat, and probably organic as well, because you're minimizing pesticides. If you take organic foods and you take people who eat mainly organic foods, they've got less pesticides in their urine. So you can see that that will most likely have an effect on the microbiome and on epigenetic change as well. So I think the microbiome answer is very much in its infancy, especially related to chronic pain.
So Jill, do you just assume, like, people don't just, if they're on a standard American diet, do you just assume their gut microbiome is bad?
Yes.
Yeah.
Because
that's where we're all starting. Yeah.
Yes. And I think, and it's really difficult in kids because the words that you use in children are really important. And I said we don't use the word diet, and I always talk about healthy nutrition. And I'm trying to go with, I'm going to be giving another talk on the impacts of just nutrition. And there's so many things within nutrition and things that we can eat that are so helpful, not just for our microbiome, but for minimizing epigenetic change and improving the function of our mitochondria. That's another complete other thesis on its impacting in chronic pain.
Interesting. Is that the talk in October?
Yes.
Yeah. So for everyone listening, that's going to be, I think that's going to be virtual and available to everyone in BC too through the St. Paul's Pain Conference. Well, that'll be a good one. Okay, that's really interesting. There's a question about the slides, Jill. Are you making these available? I mean, we have recorded the talk, and if folks are interested in a recording of it, it's going to be on our website and also sent out to everyone. But someone's also wondering if we can send out the slides.
So I will just vet them to make sure that I've got no patient photos in there and send you a vetted one with no patient photographs.
Right. Okay. Thank you. So I'll be able to send those out to everyone. Okay. Another question: what percentage of pediatric pain service patients are overweight?
So extremely good question. Not that many, interestingly. And when we look at the myofascial pain literature, increased body mass index, which I indicated in the slides, is not a risk factor for chronic myofascial pain. And so that's interesting, but I think I've outlined that the body is so complex, that there's so many things going on in each individual patient, that I think that just a generalized obesity equates chronic pain is too simplistic. But no, I wouldn't say that the complex pain population that we serve is obese. If anything, I would say they are slight, because a lot of them are competitive sports people.
And are you seeing, like, but you're still seeing similar diet issues in that population?
So one of the so I'm only going on my observations of this population and the changes that I'm seeing. When I see a very skinny little 7-year-old with myofascial pain, when they've been on their muscle health supplements for a while, they bulk out. They get better. They get better. They look better. They weigh more. And I just wonder if it's a magnesium impact on gut function and absorption of nutrients. I don't know. But that's one of my, I said at the beginning of this webinar, I was basically going on what I'm observing. And that's one of the things I observe, is that the skinny ones put on weight, but it's not overweight. They seem to go from being underweight to normal.
Interesting. There's a lot to right. There's a lot to figure out still. Jill.
Yes.
Here's a question. Someone would like to know how you explain exercise and rest to high-level athletes.
So that's a very difficult one, and you've got to go with each individual patient and the impacts that pain is having on their lifestyle. And if you have a competitive gymnast and they are determined that they are a competitive gymnast and their identity is that of competitive gymnast, you've got to work with that, and you've just got to help them try and pace a little bit better, as opposed to what I call the roller coaster, where they're doing 4 hours one day, nothing for a few days, and then 4 hours the other, 4 hours on another day, and just pace it a little bit better. One of the things that we need to advocate for is that parents and coaches are not pushing these kids at an early age, and are not pushing them to do 6 and 8 hours, and then for them not to be that 1% at the top who are going to make it. What happens to the top 15%, and 14% of them are not going to make it, and they're the ones that have got injuries, and they don't end up being a competitive gymnast in the end. It's a very difficult problem, but we go on a pacing principle with them as much as possible. But if you've got a kid who's determined and their life and their joy is competitive gymnast, you've got to work with that.
That doesn't sound easy. Okay, I've got a question, Jill. You made the comment with the baby and the chin scars, and you said you can guarantee that baby will have a mood disorder because of their chin scars. Can you unpack that a little bit?
Yeah, I was probably a bit tongue in cheek, but we see a lot. Sorry, I should apologize. No, I don't mean that. I mean that when we see chin scars which have been sustained at a very early age, in association with a mood disorder, then release of that chin scar can actually make an impact on that person's mood when it's released further down the line. What I meant was that the scar induced at a very young age has really important impacts, and one on the skin is associated with mood disorders.
And is there something around the location of that scar as well?
I don't know the answer to that. That's just way beyond my pay grade.
Right. Okay, someone's asking, how do you release a scar?
Probably best to have a look at my article on pediatric myofascial pain to understand myoactivation, understand what's happening when we release scars, because we won't really release scars when we think they are having a significant impact in myofascial dysfunction or myofascial pain. And that's I'm currently doing article on scars, which I'm hoping is going to be coming out towards the end of the year, and people will be able to understand more clearly what I mean by significant scar, because I don't mean it's not the same as a pathological scar as outlined in dermatology. And we release them by needling them, dry needling them under sterile technique. But obviously in children, you need to be doing all sorts of things to make sure you don't induce needle anxiety, and that you make all attempts to provide appropriate analgesia when you're doing it.
Thank you. Okay, now this is interesting. Someone is asking, or just they're observing that in practice, they see links with families where pain exists and autism and ADHD. Do you feel any of your pillars have a link?
Sorry, say that again.
Yeah, the question, so Richard, you might just need to provide a little more info in your question, but it says, in practice, I see links with families where pain exists and autism and ADHD. So do you feel any of your pillars have a link, I guess, with pain, autism, and ADHD?
All of them. All of them. All of them. Yes.
Yeah.
What I'm so yes, and I think that the autism came up regularly throughout that talk, related to exercise, related to microbiome, related to nutrition. So yes, I think that starting to address the 6 pillars, all 6 pillars, is really important for them too.
Right, so it's going to have impacts on other coexisting conditions.
Yes, yes, just as it does on other chronic diseases. Yes.
Yeah. Okay, Richard, I'm not sure if that didn't answer your question. Just write in clarification if it's needed. Oh no, he says perfect. Okay. Well, we are at the end of our time, and also at the end of our questions. So Jill, I just want to thank you again for a really fascinating talk, and thank you to everyone who came. And we look forward to, we're taking a break for webinars over the summer, but we'll be back in September, and hope to see you then. Thanks, Jill. Thanks, everyone.
Well, Jen, thank you very much.
You're welcome.
Bye.
Okay. Bye.
Bye.